enlightening us. We did I rather got internet for 2 hours, and the one of the best fascinating part was we touched 25,000, yes, 25,000 health workers at a grassroots level in state of Gujarat for 2 hours, and a single health worker in Gujarat state and town, are looking after 1,000 individuals in our town. So ultimately, we reach 2.5 million people within a period of 4 hours. So, Dr. Anupa, she talked a lot about child cancer awareness, treatment protocols, and everything. And one more thing I would like to add here, that the role of Dr. Anupa is incredibly pivotal because she's giving second life. She's giving second life to countless children who are suffering from cancer, and I know her for at least not less than 8 to 10 years. So, Dr. Anupa, welcome on board, and thank you so very much for joining to our show. Friday's Speech Running stage is all yours. Kindly enlighten us with everything, your knowledge, experience, expertise, and everything we learn over
Thank,
years. Thank you.
thank you so much, Shrenik Bhai. And I am absolutely honored and privileged to be amongst all of you today. And Shrenik Bhai has always been an inspiration, and we're always ready to be there for him at his beck and call. And and it is basically, it is an absolute pleasure uh, for me to be able to get a platform to discuss pediatric oncology, which is an oft ignored topic in the wide universe of cancers and pediatrics. Unfortunately, it sort of falls in a no man's land because none of the parties take it up completely. But here I am, and I will, without much ado, just get on to talking about pediatric cancers. Now, when I'm talking about pediatric cancers, we are essentially referring to the age group of 18 years and below. And let me start with the fact that when I say pediatric cancer, the first reaction that I often receive is disbelief and denial. Right. The first thing that people say is that, really, do kids get cancers? How can kids get cancers? It's not possible. It's a disease of the old, and they haven't even seen life. They don't have any addictions, and why are kids getting cancers, right? But let's start with the first fact that um, it's a harsh reality. It is there. There are a big number of children who suffer from cancer. If you look at the numbers, if I had to put it down very simply for you in terms of its statistics, if you're looking at 100 patients of cancer, out of them, approximately five would be under the age of 18 years. So, given that India has a very young population, a lot of children and adolescents make up a huge part of our population. We do have a significant number of pediatric cancer patients and a dearth of experts that cater to these patients, right? So these are some numbers from the cancer registry, right? Uh, this is around 10 years. It's been updated, but I don't have the access to the data as of now. But if you look at the 0 to 14 years age group, you see it accounts for around 31% and 26% of patients when you consider male and female. And that is a huge number. So this is just to bring into focus the relevance of this podcast or this conversation that we are having today. Now, coming to the various types of cancers that affect children, the commonest cancer that we see in children is the hematolymphoid cancers, or let's say blood cancers, cancers of the WBCs and cancers that affect the lymph node. So it is known as leukemia in medical parlance and lymphoma. So those are the commonest cancer. And among that, also you have acute lymphoblastic leukemia that makes up a huge chunk, followed by a couple of acute myeloid leukemias, which is essentially an adult blood cancer. And then you have lymphomas, which are again Hodgkin's and non-Hodgkin's. The non-Hodgkin's are the more aggressive one. The Hodgkin's are the more curable ones. In fact, and then we come to solid tumors. So these are the liquid tumors, or what you say, the hematolymphoid tumors. And then you have the solid tumors, which has a higher propensity in adults and a comparatively lower propensity in the children. So you have CNS tumors, the brain tumors, which are the commonest solid tumors in children. And besides that, you can, like today morning itself, I actually ended up seeing a 1 month old with a retinoblastoma because of, and it was very unfortunate. But yeah, so you have retinoblastoma, you have renal tumors, which are known as Wilms tumors, you have hepatic tumors, which are known as hepatoblastomas, you have bone tumors. Bone tumors is something that you really see in children who are growing fast. So there are two age groups, generally the between the 4 to 6 years, and then you see it in adolescents when they have their growth spurt, right? When they suddenly gain that height, that is when we see a high incidence of a lot of bone tumors like osteosarcoma and Ewing sarcoma. And we have a couple of germ cell tumors as well. So, yeah, if you say 80% of my practice is made up of hematolymphoid or leukemias and lymphomas, and then 20% of the practice would be catered to solid tumors and cancer-like syndromes. Um, let's understand certain differences between adult tumors and childhood cancers, right? Adult cancers and childhood cancers. Now, the first thing that that's the good. Let me start with the good news. The good news is that childhood tumors have much better survival rates as compared to adult tumors because the cell from which they originate are not the mature uh, cells or mature differentiated cells, but they are more of the immature blastoma cells, which are much more amenable and much more responsive to the various multimodality agents, essentially chemotherapy, radiation, surgery, etc. So the good news here is that pediatric tumors are different, but they're different in a way that they're also more curable. So when you treat a 5 year old and when you make him or her cancer free, and you that kid can go on to live for 50 more years, right? And that's a privilege that none of the adult oncologists gets. That's a privilege that a lot of pediatric oncologists get. So that's the good news. The bad news is that we really don't know why they happen. Okay. So that is to say that, you know, whenever I declare the diagnosis of or break the diagnosis of cancer to a family, the question is why? Like when there's nobody has cancer in our multiple generations, or of course the kid of 2 year old or a 6 month old or a 5 year old or a 6 year old has no addictions, right? Or people believe that, oh, is it he was given blood? That's why he got cancer. The reality is because he had cancer, he had low hemoglobin, and he was given blood. But people ask that, was he given blood that gave him the cancer? Is it the vaccine that gave him the cancer? Oh, the doctor, we went for fever 5 days ago. He given this medicines. He never told us this was cancer. And did the medicine do this? Right? Or because he eats a lot of outside food, does that get him the cancer? So there are a lot of myths, but unfortunately, no causative association has been established with any of these factors. So it's an unfortunate mistake. It is just a mistake that happens when one cell is being formed from the other during DNA replication, and it leads to some of the cells losing their track, getting off regulation, and multiplying uncontrollably. Right, that is what cancer is when it comes to pediatric patients. Um, Very small amount, less than 5% of the cancers are inherited or part of larger syndromes. For example, the retinoblastoma that I talked about today morning, it's an inherited gene, right? Or if there are patients with Down's syndrome, which is a chromosomal aberration, you have 3 copies of 21, those kids are more prone to getting leukemias. right? So that is less than 5% when the cancer is a part of a larger syndrome. But besides that, there are no causes that have been identified, which leads to the fact that it cannot be prevented because we don't know what causes it. We don't know what to avoid, right? So we cannot prevent it primarily or primordially, right? So the only option that is left with us, right? The only option that is left with us is to identify it early and to treat it early, right? So that's the bad news because we can't prevent it. We need to treat it early. One of the major, now let's look at some of the barriers to to getting the treatment. Why is it a long way, right? Why are we, despite, if you look at the cure rates in the Western countries and the low middle income countries like ours, right? There's a huge disparity in the cure rates. Like if you look at leukemia success rates in the US or UK registries, you'll find close to 90%. And on-field reports in India would place the standard risk and the intermediate risk cancers at 80%. So that's a huge gap, right, when it comes to cancer treatment and its outcomes. And we would like to identify that how can we close that gap? Uh, so one of the thing is, of course, the dearth of practitioners in our country. A lot of adult oncologists end up treating pediatric cancer patients, which is still fine. But there is a little bit of difference in approach when it comes to pediatric cancers because the biology is different, the treatment protocols are different, and you also have to remember that children are growing bodies. So you take into account their nutrition, their growth, their development. Fertility, so on and so forth. So those things also become important when it comes to cancers. The second is lack of awareness, right? People don't believe that when we declare the diagnosis of pediatric cancers, people don't believe it. And it is oftentimes not only just the layman and the general public, even practitioners sort of always second guess the diagnosis, even when it is white and clear. And in India, a lot of patients do rely on their general physician, on their local pediatrician first, before they believe us. So let's go through some points. Cancer takes a back seat. Okay, we are still dealing. One of the highest causes of infant mortality and under five mortality rate is still infection and malnourishment and vaccine preventable disease and acute respiratory tract infections and diarrhea that nobody really bothers. Okay, there are hundreds dying of because of these diseases. We really don't care about the five those are dying because of cancers. It's still not recognized as a specialty. So, you don't have dedicated centers, you don't have dedicated practitioners. There are delayed referrals because people do not see. There's a saying in medicine, say your eyes see what your mind knows. So if you don't think about cancer, you don't see it, right? So there's often a delay in referral because it is the signs and symptoms that are glaring at you, or maybe not glaring at you, but are subtly present and not picked up at the right time. And so patients come to us in very advanced stages, right? They're in stage 3, stage 4, they come with complications. And then it becomes even more difficult to salvage them, right? Quality of drugs and financial constraints. Of course, cancer diagnosis itself is like a doomsday announcement for most uh, families. There are questions about really whether it's worth treating. You typically get questions about guarantees and warranties, and sometimes people want to spend but they're not able to spend. There are government schemes that help, there are NGOs that help, but there are also a lot of logistical issues because these treatments are long. So the patient need, and because it's available at very select centers, patients who live in peripheries in smaller villages need to give up on their work, need to give up on their business, stay in the city, so that's a double whammy. So they're spending more and they're even stopping to earn, right? So there's a double whammy over there. Quality of drugs in India is unfortunately very questionable. Like with all the emphasis on the generic prescription, it is so difficult to make sure that you're giving the right quality of drugs. And in cancer, it's all about the quality of drugs, dosing, scheduling, tolerance, so on and so forth. Results in Western countries and in our countries is because our children, most of the time, are extremely malnourished. Okay, so they don't have the nutritional capacity to tolerate the medications that we're trying to give them. And of course, there's all myth busting. There's also a lot of myth. It's hot, and will he feel pain? And how is a kid going to tolerate chemotherapy? And, or is he going to get hurt? And he's going to lose his hair? And, these sort of questions also crop up. But let me tell you, as an expert, the doses for children are as per their weight, their height, their body surface area. And in fact, children tolerate chemotherapy drugs and chemotherapy and other cancer treatments much better than adults. And there are reasons for it. Their liver, their kidney, their heart, their brain has still not been battered by age, alcohol, blood pressure, diabetes, right? So their organs are actually functioning much better. So they are actually able to process the drugs much better. And they do not have the psychological element attached as much as adults do, right? They just know that they're going to a hospital and you give them a teddy bear and you give them a chocolate and you play up some cartoon and they're fine taking up the treatment, right? In fact, I have videos of patients who are dancing on Shiv Tanda while they're taking like their chemotherapy treatment, and it's so nice when five of them get together. One is bringing gifts for the other, and they form their own small community, and they actually look forward to seeing each other, and so. That is there. But of course, because of the malnourishment, because of the high incidence of infections, we just don't need good oncologists, but we also need a very good pediatric and intensive care and infection management team to give the best results in these patients. So these are some reasons, right? And compliance. Patients are traveling. There is some festival coming up, there is a shadi in the ghar, and there is somebody passed away, and the mother is not educated or the father is not educated, they don't understand. So, because these are long treatments, some of them, compliance has always been an issue, right? So we need to develop a system, an ecosystem where all these deficiencies are taken care of. And it starts from the physician. The first step we need to make the public aware, the primary physician aware, so that the symptoms and signs are identified early, correct investigations are sent, and there is no referral delay. So that we are able to identify the uh, patients early. Right now, these are some gruesome pictures. I'm sorry if they disturb you, but I would just try to highlight some of the red flags that can be harbingers of your child suffering from some sort of a malignancy. Now, let me put a disclaimer here. Not every symptom that has been discussed here means your child has cancer. Okay. But these are the potential symptoms if picked up on time and investigated thoroughly might be able to detect a malignancy in its early stages and help with better outcomes when it comes to cancer treatment. So fevers which go on for very long time, right? Of course, the commonest cause of fevers in our country are going to be infections, viral, TB, typhoid, hepatitis, so on and so forth. But if everything has been investigated and everything has been treated to the best of their abilities and the fever refuses to go, then say after 7 days of indoor or after 14 days of OPD treatment, then you consider something known as PUO or pyrexia of unknown origin. And that needs to be investigated. Bone marrow being one of the investigations that can lead you to a diagnosis. What you see in the upper picture is pallor. That means that the child becomes very weak, stops eating, has weight loss, becomes lethargic, looks whiter, right? That is a reason. That could be an early symptom of the blood counts dropping. What you see in the third picture are nodes. These are glands, lymph nodes that are swelling up. There could be distension in the abdomen, and these glands could be features of leukemias and lymphomas or some solid tumors that have reached your nodes. Right. Then, of course, you can see uh, bleeding, like I said, because blood cancer is the commonest cancer that we see, platelets often fall, and that can lead to dots, small dots. We see a lot of patients going to dermatologists, right, thinking it's a skin rash, but actually it's petechiae or bruises, right? And then they are investigated with a blood investigation, and they find out that the platelets are low. There could be wet bleeds. So, of course, bleeding without any trauma or with minor trauma, excessive bleeding should also raise concern. right? Abdominal distensions, right? Abdominal distension, livers enlarged. If there is a solid tumor, or even in leukemias and lymphomas, there are swellings on the liver and spleen, which can be picked up while bathing. If the mother is bathing and they suddenly feel there's a lump, that often brings them to our notice. Headaches, because I told you one of the commonest solid tumors are brain tumors. Headaches, which are not responding to routine medications. You've checked your refractory error, you've checked for glaucoma, you've checked for tension headaches, you've checked for migraines, and you still don't find a cause. You get a scan and you can probably pick up a tumor. Um, when there are brain tumors or when there are abdominal tumors, there can be vomiting. There can be excessive vomiting. Early morning projectile vomitings could be because of brain tumors, and not able to eat anything, or because could be because of a tumor in the abdominal cavity, which is compressing its size and causing the child to vomit. Uh, what you can see in this kid is the white glow, right? If you look at the left eye, that white reflects, it is a sign of retinoblastoma. So before the tumor becomes big enough and starts protruding into your orbit and causes your eye to pop out, if this white reflects, even in photographs, right? Even when you're looking at photographs, ideally you should get that red fundus reflex. You know how your eyes look, the red glow that you get during photographs. If your child is consistently not getting it, you probably want to look into the child's eye and see if there's an early retinoblastoma, because here you don't only want to save the kid, you're trying to save the eye, and if possible, you're also trying to save the vision, right? So if you catch it early enough, you first attempt is to save the child, then save the eye, and then save the vision. Same goes for bone tumors. You just don't want to save the kid, you also want to try and save the limb, right? So the earlier you detect a cancer, the more likely it is, right? So this is really not for everybody, but if there are any physicians, or even if you're going to your physicians, and if without a diagnosis, because of panic or anxiety or not being able to figure out what is happening, um, sometimes steroids are given in the periphery, which is something that you should not endorse or take unless you have a clear-cut diagnosis at hand. None of the doctors does it out of a malintent, but it could often be out of ignorance and panic, right? Because I'm not able to give any results to the patient, and the fever is simply not going, and let me just give one shot of steroid and the fever is going to vanish. And it often happens. It happens because it's leukemia fever, it's cancer fever, and it responds beautifully to a single shot of steroid as well. So that is something that you should be uh, knowing. But like I said, it's very important to establish an ecosystem where there is early referral, because a lot of our patients come from periphery. You need doctors locally to take care of minor complications, uh, to check on compliance, to follow up with the patients. There are certain chemotherapies which can be given, even locally. So if we are in contact with those local physicians, that can be done. And when there's an emergency, like if this child is living 400 kilometers from where I practice, and the child bleeds or child has a seizure, I need somebody to take care and address the immediate complication, and then uh, transfer the child with utmost care, with all the basic supportive care provided. So all this requires an ecosystem where we really look forward to, uh, collaborate with physicians, parents, families, and such good Samaritans as you, who are out there to provide patient support and awareness about the disease. Right. So I think that will be it from my end. Uh, I will be happy to take any questions if there are.
Dr. Ruba, thank you for such a commendable presentation today. Friends, in last 8 months, we have talked about pediatric cancer, lung cancer, breast cancer, gynec, and multiple other organs and so on.
Hmm.
And earlier, I did mention that we had Indian Cancer Society Delhi. We definitely believe in women empowerment, and we did a lot of, webinars, on breast cancer, gynec cancer, etc. And one of the reason was we are believing in women empowerment, but today I have chosen pediatric cancer for simple reason that every single child is having a right to survive, and therefore, today I have chosen pediatric cancer, and I have invited you to deliver talk and knowledge and expertise and everything. Dr. Anubhav, I have one simple question, that what is overall survival rate, because this is a burning question for every single parent. What is the overall survival rate for child cancer, I mean, irrespective of any segment or whatever, and what are the treatment protocols offered, and Dr. Numa, before you respond, I would like you to be introduced to our chairperson, Dr. Jyotna Govind. She is the chairperson of Indian Cancer Society, Delhi, and my very big support system at all webinars since last 8 months, for another over more than 8 months. So she's my backbone at cancer is webinars.
I
Wonderful
have
meeting you, ma'am. Yes.
nice
Yes.
to meet you, Doctor, and thank you for stepping in at short notice, as Shrenik has informed all of us. Uh, I think pediatric cancers are indeed something that we need to pay more attention to, and to educate the parents and generally the general public about the fact of how curable they are. It's always frightening when a small child develops symptoms that are simply, you can't tell what it is. Is the listlessness because of just overdoing things? Is it because of dehydration? Is it because
Absolutely.
a million other reasons? I think cancer is furthest from every parent's mind. So if we can do something for them, it is a priority with us.
Absolutely.
Luckily, in Delhi, we have very good support from a generous sponsor, and we are able to offer at least financial help in 2 or 3 major hospitals. Is there anything like that in other cities? I'm not.
Absolutely. Yes, ma'am. Yes, ma'am. There are many NGOs actually that do work in pediatric cancer. One of the
Is
most famous one
Canada?
is Can Kids. Yeah,
Yes.
Can Kids. I was at Vardia, and they have a great support system over here as well. They're also at GCRI over here. In fact, they have recently started their home away from home a couple of years ago, even in for the patients that come to the civil hospital over here. And besides that, also we have these government schemes like the Maamritam Yojana, PMJY schemes in Gujarat. We have like the Bhamasa Yojana in Rajasthan. There are the CM funds in Maharashtra as well. Institutes like Vadia have their own SSD, social service departments. Even Tata has its own big funding. So there is a lot of financial support that is available. Now, we have been trying to appeal to the government to sort of because they require a DM. Now, there were not enough DMs in pediatric oncology, so we have to go ahead with fellowships, and we're struggling to still letting the government know that needs to be recognized. And the other major thing is that some of the protocols are really outdated. So we are in the process, even as a PHO, the IAP's PHO chapter, the Indian Academy of Pediatrics PHO chapter is really trying to push that we need approval for the modern drugs and the modern protocols that are available at hand. So yes, there is definitely a lot of support. I think we require more support, and CanKids does that. It provides for social workers and nutritional support as well, and including nursing staff and the other things. Even at GCRI, GCS, and other hospitals. So, like I said, there is funds. There are funds, but there is no ecosystem which allows these funds to be really put to the best of their use.
Mm.
Even diagnostics are an issues because cancer diagnostics are very heavily priced. So it is at that level that we really look for a lot of support, because that is the first jhatka. Like your child has cancer, and then you have to do a battery of reports, and there is ideally we should not be compromising on those reports if we really want to deliver. You want to stage and risk categorize the kid correctly, appropriately, and not overtreat or undertreat the child. So yeah, those are some real challenges. But yes, there are these are getting increasingly identified, and we're getting help. To
Just
answer,
for your
yeah,
information,
yeah.
CanKids started at ICS Delhi. It
I'm
was
sure.
part of our operations for a few years, and
Right,
then
right,
they went on to do their independent work, which is
right.
quite marvelous. And we are in touch. We collaborate with them. You might
Absolutely.
suggest to them, like lately, we have started an initial diagnosis fund.
Yeah.
We know that when patients get an estimate of what their initial
Hmm.
test costs, they most often run away.
Yeah, true.
They feel that if the tests are so expensive, the treatment is going to kill them.
Yeah, and
So
absolutely that's not the case.
it's
Unfortunately,
not.
in pediatric oncology, if you compare adult oncology, our drugs cost peanuts. Like we have 50 rupee drugs, honestly. It's so difficult to
I
convince
think
the,
that is what you need to get out there. That
yeah,
you need these initial tests, and maybe
yeah,
Can Kids and your other supporters can help you with that.
yeah,
It,
yeah.
the cost of initial tests is actually very small
Yeah.
comparatively. Comparatively.
Compare, yeah, but if like I said, my commonest tumor cancer is a leukemia. So I need the bone marrow, I need the flow cytometric
Mm,
examinations, I need the
mm.
fish cytogenetic examinations, and I need to do a CSF, and I need the echo and the X-ray. And even if I put together, even if I do as much as cost cutting and request the labs to cut down as much as I can, they can, it still amounts to a 30K, 35K, 30.
That's
Yeah, that's a
that's still small compared with what you.
I know,
So if
but
you
it
get
is,
that to the parents, you can
yeah, I
get
know.
that to the parents, and they'll
Yeah.
then follow up with the rest of the
Absolutely.
treatment.
No, no, that's what we've been doing, and that's how we've been able to. And we also provide as much support from our end, and the
Mm.
labs and the doctors are kind enough to help us through that as well. To answer your question, Shrenik Bhai, what is the survival rate? Now, like I cannot give a blanket umbrella answer to that, because it definitely depends on the type of cancers. But if I had to break down, let's say if you look at blood cancers, leukemias and lymphomas, if they are not high risks, they are not high risks. A good estimate would be around 80%. So that's you're and obviously it's in terms of 5 year and 7 year overall and disease-free survival rates. So you're looking at 70 to 80%, which is a big number. You're able to cure like 8 out of 10 kids, which go on to living near normal lives. So that's a big number. If you look at tumors like Hodgkin's and Wilms tumor, you get cure rates up to 90%. Right? If you're in the stage one, stage two, you get cure rates up to 90%. There are tumors which absolutely, if identified early, can be treated without any other treatment, like neuroblastomas or Wilms tumors that identified very early can be treated with just surgery or maybe very minimal chemo. Burkitt's lymphomas have cure rates around, group A and B's, like the initial two risk categories, up to again 70-80%. If you're looking at bone tumors and soft tissue sarcomas, you're at a 60-70% because they often come advanced. And liver tumors and all, again, if they're early stage, pretext 1, 2, 3 stagings, if you're in the hands of a good surgeon, we have a lot of survivals for those tumors as well. So Overall, you can place it at a 70%, 70-80%, which is huge in terms of a diagnosis like cancer. So it's definitely not worth giving up the fight on such kids. Like, let's not play God for them and let's give them their chance at life. And that's the problem with pediatric oncology. You know, the decision is not in the hands of the patients. It's sometimes not even the hands of the parents. It's in the hands of the extended family and the grandparents and the Sage who's going to sponsor the treatment, which is very, very uh, unfortunate. So, but yeah,
Dr.
that.
Anupa,
Dr.
Dr.
Yes, sir.
Anupa,
Yes, sir. Yes, ma'am.
can
Uh,
you tell us the potential side effects of the treatment for a child when they grow up?
So, ma'am, there are, if you look at any chemotherapeutic agent, there are certain side effects depending on at what stage and what intensity of treatment that we are giving. The immediate side effects would be vomiting, hair loss, so on and so forth,
No,
immunocompromise.
the side
The
effects when
long
they're growing up.
As an adult.
As in adults, yes, ma'am, I'll come to that. So some of these side effects that you're looking at depends again on the category of drugs and the cumulative drug that they have received. For instance, anthracyclines can lead to cardiac insufficiency in the long term. But just to caveat there that these are the survivor study results that have happened later on. So when the initial protocols were there, that's why there's a lot of emphasis on risk categorization. So for instance, if the cumulative dose of donomycin or anthracycline is more than 375 milligrams per meter square, you see cardiomyopathy. So most of the protocols now see to it that those drugs are kept below those cumulative dose ranges, and we include other drugs to compensate for it. So that is one. Of course, there could be effect on fertility, right? Like in any other. Um, but let's also understand that the effect of fertility is seen only when the chemotherapy is given to prepubertal and pubertal kids. Because in the other kids, in the very young kids, the germ cells are not in their active stage. So you really don't end up affecting, especially the commonest tumors. When you're talking of leukemia and lymphomas, we have many many patients have become successful parents. So that's that. Every chemotherapeutic agent is a carcinogenic itself. Right? Every chemotherapeutic agent is a carcinogenic because the mechanism of action is DNA damage. But so secondary malignancies are also a possibility, but the secondary malignancy will occur only if the child is cured of the primary malignancy first, right? So let's also be very clear about that. Like for the child to get a second malignancy, has to survive the first malignancy. So the chance of having a second malignancy is very small compared to the chance of losing the child to the first malignancy. So that's there. Um, yeah, these would be the major categories. Um, like I said, the treatments have been modified. For instance, if you're thinking of Hodgkin's lymphoma, it has also been categorized as per the gender. For in leukemia, first everybody used to get CNS radiations. Now we don't get CNS radiations. There's a very small number of patients that get CNS radiations for CNS prophylaxis. We try and give intrathecal chemotherapeutic agents. So that is there. There are psychosocial disadvantages of that are seen in survivors of cancer children, and that is again amenable to correction, provided we give them the right ecosystems. So because the parents become overprotective, don't allow them to go to school, cater to all their demands. They become, you see attention deficit sort of problems in them, you see behavioral problems in them. So those are the kind of problems that are also seen. We really haven't seen any direct effect on IQ unless there is a lot of CNS
Very
directed
frustrating. I
therapy.
thought she was much better.
I thought, but I don't think.
wait,
We
Ritika,
only need people.
Ritika, please unmute, all rest of the attendees, it's Priya, Jyotaji, myself, and the speaker. I want everybody to be, muted. We
Okay,
don't
sir.
want any distraction.
Okay, sir.
So any other long-term side effects that you have a particular concern for, ma'am?
Yes, sir.
Ma'am,
I
does that answer your question?
Can I
Yes,
ask
it
you,
does.
do you have a survivorship program?
We don't have a survivorship program, unfortunately, in Ahmedabad that is very clear cut established. The highest patient load is at GCRI, but I don't know there is a survivorship clinic that runs there. We would love to have it, but uh, I think it also depends on how the practice is in a particular city, ma'am.
Yes.
In Ahmedabad, there is only one identified center, if you can say, which receives a maximum pediatric oncology load, which is GCRI.
Mm.
And the rest of the practice in the city is pretty scattered among pediatric oncologists who run their own practice. So there's no single group of pediatric oncologists or an established pediatric department in any of the corporates, unfortunately, where such a survivorship clinic could be established. But we would love to collaborate with CanKids if it is willing
I
to
think if you
provide.
could collaborate with Indian Cancer Society in Mumbai, they
Right.
have a program which is called Ugam.
Yeah, I'm aware, ma'am. I'm
Yeah.
aware.
And
We
maybe
will.
you can contact Purna Kurkure.
Yeah, yeah, absolutely. We know Purna ma'am very well.
I'm
So,
sure everybody does.
yeah, anybody who's into pediatric oncology would know her. So, yeah, absolutely, ma'am. We can, like I said, but it's very scattered right now.
Mm.
Uh, Till say up to 3 years or 4 years ago, there were just the two of us doing pediatric oncology exclusively in
Mm.
Ahmedabad. I mean, it was being run, but it was being taken care by, uh, a mix of adult oncologists as well.
Mm.
But over the last 3, 4 years, now we are around 8 to 10 oncologists across the city and state, and we can probably now put up that front and make our demands. So,
Yes, do that, especially for a survivor
yeah,
clinic and a survivor program, now much more than a clinic. You have
yes, yes.
a target of how far you will go.
Absolutely, absolutely, ma'am. So no, no, that's definitely in the offing, and we will be looking forward. I would
You tell
contact
us
my other
when you're
colleagues.
ready. Yes, you tell Shrenik Bhai when you're ready.
Absolutely, we will. If we want, I can put up. I can ask all my colleagues and seniors to meet you, and
Why?
we can
Why
organize a joint
they
meeting.
don't need to.
Uh,
They can. You
Anupa, Dr. Anupa, let's plan out our meeting. I mean, in-person meeting. Let's discuss it out because as I said earlier, apart
Mm.
from women empowerment, I strongly believe in child empowerment because they are our future and
True.
they have all right to survive. So let's focus on that. And whatever it is, the adult cancer is becoming so much talked about that pediatric cancer is absolutely the sideline. It is absolutely
Yes.
in sideline, and I would like to bring that pediatric cancer into the front line. So that children can survive and they can make a better future of our country. And we also need
Absolutely.
oncologists. I want the survived children become oncologists in a coming future so that they can
Absolutely.
save many more lives. So that is one of the key reasons, and that is why I have invited you today. To share everything you know about pediatric cancer.
Yes, yes, definitely. We will. There's so many things that we need to do, but of course,
yes,
every day, each day at a
you
time. Yeah, yeah, each day at a time, and
one
every
step
patient
at
is
a
a
time.
struggle, and yeah. But yeah, I'm not. We definitely see more awareness than there was a decade ago, for sure. I have been doing this for a decade now, professionally as a practitioner, and I definitely see that a little bit of a shift in terms of attitudes for referrals, patients, outcomes. Uh, yes, yes, we can definitely even look forward to getting a survivorship clinic, getting parent support groups, uh, you know. But yeah, it's still lagging when it comes to Mumbai, Bangalore, Delhi, Chennai sort of setups. But we'll reach there. So yeah, that's about it.
Dr. Jodaji Priya, you may not be knowing because, I talked earlier, but me, Dr. Numang, and three others cancer specialists, we educated around 25,000 healthcare professionals, at a grassroots level through live telecast on behalf of Gujarat State.
Hmm.
So that is what we have done before 5 years. Since then, I know her capabilities and everything she's doing, in a pediatric cancer. Uh, Priya, if you have any question, please let us know.
I thoroughly enjoyed Dr. Anupa's answer to those long term side effects of
Yes,
treatment.
ma'am. Right.
It's because that's
Uh,
something I don't know. Do you all counsel the parents? Do you tell them?
So,
Are they
ma'am,
afraid?
right. So let's understand this from two points of view. There is an idealistic way of practicing, and then there's a pragmatic way of practicing. When we, no, I'll be very honest here
Yeah.
because if I go on to tell them that your child is probably never going to, your girl is never going to have a baby, they might not just decide not to treat the girl at all. Right. So it depends on the educational level of the patient that I'm dealing with, the attitude towards the family that they have towards the treatment. It also, it also depends on what stage would I want to declare those side effects to the patients. So, to be very honest, we do talk about these side effects, the potential side effects, we hint on them, but we would not emphasize it enough to discourage them from going ahead with the treatment.
Hmm.
So it has to be a very fine line about declaring the truth. And so if I tell them, so I know with ifosfamide, you can get neuropathy, and that's a 0.1% chance. So if I tell them, I give you ifosfamide, the child might get a neuropathy, he might have seizures, and he might die. The patient said, "Oh, chalega nahi lena hai." So when it talks whenever you're trying to explain the complications of a disease like cancer, it's always you always have to be it's case to case and individual to individual basis, right? So that's how we practice, ma'am. Yeah. They're
Very
definitely
right.
counseled.
Very right,
Yeah,
doctor. And that's a very honest reply which you've given,
yeah.
because
Because
the aim is first to save the kid and then look at how you
हाँ, मैं
can.
लॉन्ग टर्म साइड इफेक्ट्स तो तब होंगे ना जब बच्चा बचेगा।
Hmm.
अभी ट्रीटमेंट नहीं लिया तो बचेगा ही नहीं, तो लॉन्ग टर्म साइड इफेक्ट्स कहाँ देखेंगे मैम? सो वी हैव टू बी वेरी इनफैक्ट वी हैव टू बी वेरी वेरी टैक्टफुल about talking about side effects in a society like India. Any which ways there's Google, so they can always Google the side effects and come back questioning even the 0.5% side effect that they see. And we always answer them that it's a possibility, but you would not know unless you give the drug. So,
That's right.
well, right.
Priya, this is the reason I am bringing such commendable case speaker to share their knowledge and expertise, so that people can get to know much more instead of googling and getting misleaded and probably not opting for the right treatment, etc.
Hmm.
So yeah, so I
That's
think
and yeah, another thing that we really, and I see this happening. In fact, yesterday itself, one patient called me and saying that this is the parent of a T cell lymphoma kid, T cell leukemia kid, who's 2 years post treatment doing well. Now his younger brother had a UTI and had some. They got a sonography and they got his blood reports, and the CRP and the blood counts was slightly high, and they panicked and said, "Madam, इसके भी पेट में सूजन आ रहा है, count बढ़ गया है." Right. So the other thing that the parents concern, once in the family, they're obviously very anxious about the second kid, which plays havoc to their psychological conditions. We have had parents who've gone into depression and committed suicides because of childhood cancer. So a lot of emphasis on the parental anxiety should also be placed, because that's oft ignored. Nobody actually addresses the caregiver's stress. So everybody talks about the survivor, nobody actually talks about the caregiver. And especially in our case, it's very important because the patient hardly knows anything. It's always the caregiver that is undergoing the trauma, even more than the patient. And then they have concerns about मेरे दूसरे वाले बच्चे को इससे इन्फेक्शन होगा, सो दे ऑफन थिंक कैंसर इज कंटेजियस. सो आई ऑलवेज से, मैं उस हिसाब से तो मेरे हर बॉडी में कैंसर होना चाहिए था अभी. एवरी ऑर्गन ऑफ मी शुड हैव कैंसर. आई एम डीलिंग कैंसर डे इन डे आउट. बट दैट्स अ वैलिड कंसर्न. वी ऑफन टेल देम, नहीं नहीं, छोटे वाले को कोई खतरा नहीं है, बड़े वाले को खतरा है. छोटे वाले को, इफ ही हैज a viral infection, please don't let him go near the other one. So that's one thing. I think that that's a big dearth which I feel is not looked at, is the whole parental anxiety. So many parents, even when we give them, please send your children to school, please send them to school. They're normal. The whole point of treating them was to help them lead a normal life. Right. And if you're not allowing your kid to do that, what's the point of treatment? So, so these are things which also need to be addressed, especially in pediatric cancers. Like I said, of course, you address what the child goes through, but there's a lot that the parents go through as well. And that stays, and it's very difficult to erase that out of their memory. Every fever, they're panicking. Every note, they're panicking. Every 4,000, 5,000 is the limit, and they get 5,700, and they're calling me 5 times. So, that's also something that I hope is addressed at
Very
some point.
commendable for you, doctor, because if you made them so alert, I think it speaks a lot about how you've been looking at them. So
No,
congratulations.
it's again, it's always, you don't know. It's such a fine line where to, like I said, that's why I was a disclaimer. Every fever is not cancer. Every time your child bleeds, please don't rush to the doctor thinking it's cancer, because you want to make them aware, but then you don't want them to interpret it wrongly. But oh yes, but if I'm talking about how aware my patients are, they're very aware. Like most of the kids, they know. आजकल IT होने वाला है. Do I need to eat? Can I eat? Can I not eat? I want to do drawing, so please don't insert an IV in my right hand. Please insert it in the left hand.
That's very clever.
So they would come and tell me that they would have picked their vein and come. And so it's they're very cute. And they, like I said, they actually put up with the treatment much better than any adult would. They like smile through it, which is just amazing, which is magical. The way these guys deal with the treatments, it's just amazing. So yeah, that's that.
Uh, I think that is all. I mean, that is anybody's having question else will wrap it up the today's session, which was quite enriching, enlightening, and everything she talked about. I must say, uh, I would say magically she has explained everything so clearly, black and white, not out over it. I guess this is all for today. Dr. Numa, thank you so very much for your very generous and prompt support to my phone call this morning. Namely,
No, sir, there
grateful
is no questions.
or anything. Fine, fine, fine. So, thank you, everyone. Thank you,
Thank you
Dr.
so
Numa.
much again. It was wonderful interacting with
Thank
all
you.
of you,
Thank you so much.
Thank you
and
so much.
Thank you
yeah, and
very
Thank
hopefully we
you.
will take the suggestions made here ahead. Yeah, with all your blessings and help.
Absolutely.
much. Forever and day, get in touch.
Thank you so much. Bye.
Thank you.
Dr. Jyotadi, I will bring her along with me to meet all of you.
That's
We'll
right.
definitely look forward to it.
Yeah.
Yeah, whenever we
Thank
can.
you. Yeah,
Yeah,
bye bye.
Bye bye.
pleasure. Bye.